Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Nichole Cubbage. She's a research scientist, and today's Kevin MD article is The Silent Grief of Vanishing Twin Syndrome, Why Words Matter in Healthcare. Nichole, welcome back to the show.
Thank you for having me, Kevin. It's good to see you again.
All right, so I think you were last on a few years ago talking about vanishing twin syndrome. So tell us briefly just some context as to what that is, and then jump into your most recent article and what it's about.
Well, the very definition of vanishing twin syndrome is complex. It's even more complex than I had initially disclosed in our first podcast together. Since that time, I've undertaken a whole doctoral degree, and I have come to find that there are different definitions of vanishing twin syndrome in the literature. However, the most universal and most cited is when a loss of one or more multiples occurs during any trimester in pregnancy. There are three kind of general outcomes that can result of this. We could have full or partial reabsorption. There could simply be a blighted ovum, which is an empty sac. There also can be a sac with an embryo that has ceased developing. And the most severe option typically is a fetus papyraceus or conjoined twins. The fetus papyraceus is a paper-thin fetus. It's when a fetus gets compressed against the surviving multiples and the placenta and the mother. And this can kind of vary, again, depending on the type of multiples, as well as some other circumstances. But there are other definitions in the literature that imply that vanishing twin is only unique to twins instead of also being applicable to higher order multiples. We know that it occurs in more than 50% of triplet pregnancies and more than 40% of twin pregnancies. And it occurs in at least 35% of all pregnancies conceived with ART. So that's a pretty big statistic. Many vanishing twin syndrome cases, because of what appears to be the ambiguity around diagnostic terminology, often go unnoted or not noted with the term vanishing twin syndrome. And even in many other cases, there are patients who will never go diagnosed at all because by the time they receive care at their first obstetric appointment, the twins have often vanished, or the multiples, I should say, have vanished. Though this is not always the case, most often they do typically vanish within the first 13 weeks of pregnancy, so by the end of that first trimester. But many women do not have their first obstetric appointment until 10 to 13 weeks. This can vary, obviously, depending on location and a multitude of other factors for healthcare access. But in the United Kingdom, for example, most patients don't have their first obstetric appointment until that 13-week mark. So for many of those patients, VTS will have likely occurred by that point. But more research is really needed to kind of understand those statistics and really understand better uses of similar and diagnostic terminology that's used in cases of vanishing twin syndrome.
So tell us about your latest Kevin MD article, and it surrounds the way that healthcare clinicians communicate to their patients about vanishing twin syndrome. So what's your article about?
So really how the way that we communicate matters. The timing of when we communicate, the words that we use when we communicate, the mannerisms in which we communicate, all of those things go into affecting the patient experience and potentially patient decision-making and outcomes. When you are talking about properly informing a patient that a miscarriage has occurred or a missed abortion has occurred to some degree, ensuring that the right terminology is used so they can understand the full scope of what has occurred is very important. In a lot of cases, including my own VTS case, many women are diagnosed with the term blighted ovum. And there's really no further explanation as to what that means. A lot of the participants from the study that we just conducted mention that when they were told about the term blighted ovum, some of them said that it was a life that had tried to form, but they were told just wasn't able to for some reason. Some of them had indicated that they were informed it was potentially due to genetic reasons, which seems to be the general consensus in the literature for the cause of vanishing twin syndrome. But most of them were not actually given much explanation as to what the blighted ovum meant or what the potential risks were to the surviving multiples. And that is exceptionally important when the burden of care primarily lies on the patient, the parents, the family to ensure optimal outcomes for the surviving multiples.
So, for those with vanishing twin syndrome, if they experience a suboptimal communication, just tell us the spectrum of emotions that one feels just from the people that you talk to within the community.
Well, just to start off on a positive note, it always unfortunately kind of goes down the negative. There were a number of participants who had positive experiences with their providers that felt very informed, very safe, very knowledgeable, like they knew what to expect. And for the vast majority of patients, though, over 50% of the participants, I think they rated it as a -1 scale of, I think it was -2 to 2. I have to look back at my own study, but the scale was a negative. It was a sentiment score scale ranked from -2 to +2, and more than 50% of participants rated a -1. Now, the vast majority of participants were from the United States, but we had over 115 participants from, I think, 18 nations in 3 different hemispheres, and it was very insightful. But most of them were anxious. They didn't know what to expect. Most of them felt very sad and just underprepared. In many cases, including my own, a lot of patients wanted to know how to prepare for the birth, and that included the handling of fetal remains at the time of birth. Since there's some ambiguity as to what can occur with the remains throughout pregnancy, there lies the question of whether or not they'll be present at birth, and if so, how are those memorialized or disposed of in accordance with the law and patient desires and needs. And so that was a big cause of uncertainty, and that seemed to really vary by location because, again, the laws surrounding the handling of fetal human remains and what defines human life varies so greatly, and there's really not much of a universal definition. As many listeners probably know, there's been a philosophical debates about what constitutes life for a very long time, and not even trying to get political about it. It's really a matter of what the patient needs and believes in. And I think accommodating the patient needs in healthcare is the priority. From a clinical standpoint, the vast majority of the literature and providers, from at least the participants that we studied, appear to have defined life at the beginning of a heartbeat or the cessation thereof. But if you have vanishing twin, or if you have a case where a heartbeat was never detected or there was never a heart to begin with, there may still be some wishes on behalf of the patients to acknowledge the life lost. And from a clinical standpoint, that can be difficult for providers who have seen developing fetuses come and go. It's par for the course, and it's a tricky place, but the most important thing is just to prioritize the patient needs and wants.
So, give us an example of some of the language that you would like to see used more often, or some of the mannerism, or some tips that you could share with clinicians when discussing a vanishing twin syndrome diagnosis.
So this is a really interesting point. There's a set of guidelines that refers to vanishing twin syndrome as the vanishing twin phenomenon. And I think that very distant language in this particular set of guidelines, which serve as a diagnostic criteria for ultrasounds, and that's really kind of the front line point of diagnosis right there in VTS care. They refer to VTS as a phenomenon, and that distant language could be potentially harmful because it is, well, to some degree, it is a phenomenon. Everything is kind of a phenomenon, right? To some degree. VTS is also something that we have clear diagnostic criteria for, despite all these various outcomes that can occur. And so I'm writing a literature review right now, and one of the things that we're working on is thinking about potential terms to use instead of vanishing twin syndrome. There is one term that has been proposed that I'm particularly a fan of. It's called womb twin, and it really encompasses all the different types of loss that can occur. Vanishing twin, again, kind of implies that it only is applicable to twins, or that twins plural vanish and not just one of twins or one of more multiples. And I think that that's really important to account for, is to be inclusive in the terminology that we use. And when we use the term womb twin, that could potentially, I don't know, I want to say it's better, but it's hard to argue that it is actually better. We could also use a spontaneous loss of a multiple pregnancy, or a missed abortion of a multiple pregnancy. These are all terms that could be considered, but it is very difficult to find. As somebody who really loves language and philosophy of language, it's very difficult to find a good term. The term womb twin was created, I believe, by Althea Hayton. I have yet to find an earlier use of the term womb twin in academic databases. She is not included in the National Health Database, but she is included in others. I think EBSCO has her, and she uses this term. And then she also wrote about, she's a licensed British therapist, and she also wrote about some strategies for how to work with vanishing twin syndrome patients. Is potentially a whole podcast in itself. But that term may be more inclusive. In any case, if we are going to continue forward with the term vanishing twin syndrome, there has to be a level of education, I think, that kind of comes with it. One really amazing way that providers are being educated on multiple loss right now is through something called the Butterfly Project in the United Kingdom. Dr. Embleton and his team over there's Dr. Rankin and a number of other really amazing folks, created the Butterfly Project. It has provider training modules that are free up until a certain point. They're sponsored by the National Health System, and you could take them on your own time. If you look up the Butterfly Project and Dr. Embleton, NICU, you'll find it. Most of the training are geared towards NICU providers, because that is where we see a lot of these patients first being treated. However, there is a lot of work that also needs to be done when it comes to training providers in obstetrics and even in pediatrics, because the continuity of care really goes throughout the whole course of life. We need to account for that. It begins in the prenatal environment and then continues on, or may continue on. We don't know, not necessarily everybody will have effects, but there will be a good portion who do. And what's also important to consider is that a lot of our current testing methods are for determining the molecular impacts on surviving multiples. So future guidelines and research really ought to account for that when they describe the frequency with which VTS occurs. Because if we don't really have the testing methods to adequately account for certain rates of things like chimerism, for example, it really is difficult to say what the outcomes are with certainty. Many testing methods have very inadequate thresholds, or they aren't able to differentiate things. Like in SNP microarray testing, we can't, determine if extra DNA is, coming from the mother or a deceased fetus, things like that. And so yeah, I hope that answers your question.
We're talking to Nichole Cubbage. She's a research scientist. Today's Kevin MD article is The Silent Grief of Vanishing Twin Syndrome, Why Words Matter in Healthcare. Nichole, let's end with some take-home messages they want to leave with the Kevin MD audience.
My take-home message for the listeners today is that, again, words matter. How we talk about things, not only the words that we choose to describe them, but the mannerisms in which we use them can really impact the patient experience and how patients view themselves, what is happening to them, and their disposition moving forward throughout such a fragile time in life, such as pregnancy. So with that, I thank you for your time today, Kevin. As always, you're amazing, and I appreciate you.
Nichole, thank you so much for sharing your story time and perspective, and thanks again for coming back on the show.